Tokyo Live Endoscopy 1.
It's a real pleasure for me to introduce Dr. KenOhata, who is an experienced endoscopist with a specialty in endoscopic submucosal dissection. He is now director of the Endoscopy Center of NTT Medical Center Tokyo in Tokyo, Japan. He graduated from Nihon University School in Medicine in '98, and he completed internship at Japan Railway General Hospital. Then he moved to the gastroenterology division of the NTT Medical Center Tokyo, and he was raised as director of the Endoscopy Center in 2013. His expertise in diagnosis and endoscopic treatment of early stage cancer of all the GI tract is well known, with a special concentration on ESD. And his ESD experience started in 2000, the introductory era of ESD. He operated more than 4,000 ESD in the pharynx, esophagus, gastric, duodenum, and colorectal. He's also a very highly motivated educator of ESD at the Endoscopy Center of NTT Medical Center Tokyo. And he's also keen on promoting ESD abroad, especially in Russia and China, where he's a visiting professor in several universities in China. His endoscopy center ranks #1 in Japan for the number of ESD performed. And it seems that NTT Medical Center is the highest volume center in Japan. So it's a pleasure to see his video case on colorectal ESD.
Thank you. Thank you for your kind introduction, Professor Dupré, and also thank you for moderate this session from early in the morning. Thank you so much. And today I'd like to show my procedure, Colonic ESD procedures in video, and later please discuss about some tips and some knowledge. Thank you. So let's start my video, please. Today, I'd like to show my Colonic ESD with no-cut version videos. So the today case is a 70-year-old man with a rectal lesion. The colonoscopy revealed after EMR demonstrate a recurrent LSD non-granular 2A type lesion on the left sigmoid colon. The lesion is on a fold, and the previously performed EMR and clip closure. This is our settings. This time we use upper GI endoscope Pentax EG29, the therapeutic endoscope, because the lesion is located in the rectum, so the upper GI is suitable for this kind of lesion. And then knife, I use the dual knife 1.5 mm in diameters. And electrosurgical unit, I use a BIOS 300D. And the cutting mode is endocut I effect 2, duration 2, interval 2. And the coagulation mode, I use effect 3 and post coagulation 45 watt. And I use hyaluronic acid solution for injection and mixed with a little bit indigo carmine. First of all, before starting colonic ESD, the important thing is to assess endoscopic maneuverability and assess impact of gravity. Previously, the patient is in a spine position, but the gravitational force direction was worse. So now the patient has moved to the right lateral side and the approach became much better. The gravitational force direction became much better. So we should start the ESD in this position. Check the gravity and the scope maneuverability before procedure is very important keys. So, and this region was initially removed with EMR and clip closure was done. The previous pathology showed the intramucosal carcinoma. That means high-grade dysplasia in Western pathology. So it was likely incompletely resected with tumor recurrence. So this region has some potential of involving the cancerous component inside the region. So en bloc resection is favorable, so we decided to use the ESD. I think ESD is better than re-EMR. The strategy is as follows. So firstly, we make a flap, and there is likely significant fibrosis on the distal side and the inner side. This is likely to difficult step in the resection. So we will inject into the area to check if we can lift it. If it has adequate lift, we will start mucosal incision here and make a flap. So let's start the injection. In this case, I use a 23 gauge and a 4 mm length injection needle. And firstly, I use the saline for injection to find the adequate mucosal layer. If I could get good swelling with the saline, then change to the hyaluronic acid solution. I'm searching the adequate depth of the mucosal layer. And again, I will try to find adequate plane of the mucosal layer. And now I could get a swelling, so I change to the hyaluronic acid solution. Just under the region, the fibrotic area will be existed. So, if there is a severe fibrosis, the region will not lift up, instead flow out of the sides. So, in this region, I think the injection solution was spreading around the region, not only under the region, but also flow out to the side around the region. The surrounding area is lifted and the fibrosis area is relatively depressed. Therefore, sometimes too much injection makes the situation worse. So, to be careful not to inject too much is important, especially in like this fibrosis cases. And the next step is mucosal incision. Start by cutting the area where the mucosa has lifted well. After cutting this, you can see the mucosal layer and fibrosis. So the mucosal incision is made by endocut eye mode. And after first incision, you can see blue stained mucosal layer. So then continue dissection to make a flap. So continue the dissection where there is no fibrosis, and then move to fibrotic area. when you see the vessels, we use coagulation mode and move the tip of the endoknife slowly to prevent the bleeding. And then I use endocut mode to cut through the carbonized tissue to open the soft submucosal tissues. So when you see the vessels, move the tip of the endoknife slowly and use coagulation mode and supply the power a little bit longer time to prevent the bleeding. And after the coagulation, the tissues often carbonize and shrink. So then use the endocut mode to cut through this carbonized tissue. This is the tips of the dissection. Use coagulation mode like this and then cut with endocut mode. That is the reason why I can keep an adequate submucosal layer. And to overcome the fibrotic area, you must keep normal mucosa on the lateral side of the lesion, both sides of the lesion. By doing this, you can keep a traction to the center, the fibrotic area, as it is held by the lateral traction. This way, I can see the better recognize the line which we should dissect. Now we can see the muscle layer. So please remember to dissect the submucosal layer just upon the muscle layer. Currently, the maneuverability is quite poor. So, and my right hand is fixed to grip the scope. No movement, fixed. So the dissection is completed only by the angle manipulation with my left hand. So my only using the small wheel to use the right and left side is important. The right hand is fixed and move the tip of the endoknife with the small wheels. So I use the base of the thumb for up and down, big wheels, and use the tip of the thumb for the right and left angles, the small wheels. That's very important tips. In this case, the scope with maneuverability is quite poor. So I only use the right and left angles to dissect the submucosal layer. So now you can see how the traction by lateral side normal mucosa is effective. So the center of the fibrotic area is stretched by the lateral traction. That's a very important strategy to remain deep by both sides of the normal mucosa. It's very effective to keep a good operation view. So in this situation, additional injection is not necessary. But I think as the blue stained injection solution, I can recognize the submucosal layer more clearly. So I decided to do additional injection. But actually, in this situation, when I release my right hand, I'm losing the view. So very difficult to keep the operation view without holding the right hand. So we have searching the adequate dissection plane by injecting the blue stain solutions. Maybe here is mild fibrotic tissue, but this is adequate dissection layer. So the blue stained injection solution can brings a good visualization. So I think the main fibrotic part has now already passed. So in this case, the fibrosis was not severe as I expected previously. I think the fibrosis was existed only in the shallow submucosal layer, and by dissecting the deeper submucosal layer, I didn't encounter the severe fibrosis. So maybe the EMR was performed in a shallow submucosal layer, and my dissection plane is more deeper layer, so I didn't encounter the severe fibrosis, I think. Now my dissection plane became a little bit shallow, so I changed the dissection plane a little bit deeper, like this. So here the dissection line was too shallow. So I have to change the correct layer, more deeper submucosal layer like this. So ESD can control the adequate dissection layer like this. This is shallow part and the deeper part of the dissection plane. The difference is very important. And we'll check the retroflexion view. And I think already the majority of the region was dissected. So now we will make the endpoint of the oral side with a retroflexion view. And then we will check the endpoint like this. So now you can see the tunnel. So the forward view or retroflex view both okay. And beta scope manipulation is okay. In this case, the retroflex position is better compared with forward view. So I approach like this. And we can see the tunnel. We made a tunnel like this. So this case is assumed to be a case with fibrotic lesion. But I think it seems the snake cut the shallow submucosal layer only. And that is why the fibrotic tissue was only in the shallow submucosal layer. And I dissect just upon the muscle layer. I keep in mind to dissect just above the muscle layer. So my dissection plane is deep. And as a result, we dissected under the fibrosis, and we didn't encounter the severe fibrotic tissue. In addition, with the traction on the normal lateral side mucosa, we are able to cut deeper layer easily and with good visualization. So you can assess where gravity is by where the fluid has pulled. So in this case, it's on the left side. So this means that the tension is applied to the right side. So therefore, we will cut the left side mucosa first. And then lastly, cut the right side mucosa side. That's very important. Now the region is removed. Fortunately, we were able to finish this quickly. In this video, no cut version. So whole procedure I showed. And in summary, this is a recurrence of an intramucosal adenocarcinoma after EMR. So I think an option may be again trying to remove with EMR or underwater EMR, but the snare may slip with the EMR, and injection show the non-lifting sign positive, and en bloc resection may be difficult. The previous pathology showing the high-grade dysplasia, intramucosal adenocarcinoma. So I think remove en bloc is better. So we choose to use the ESD. So please observe the backside of the specimen. Can you see the center fibrosis? So this means this region has a fibrosis. But today we didn't encounter the fibrosis. That is why we dissect the deep submucosal layer. That's very important. So we can manage to avoid the severe fibrosis. That's important tips, I think. The resected specimen showed well-differentiated adenocarcinoma. The depth is intramucosal cancer, and ESD could remove the region completely. So today's my video is no-cut version, and we have an online salon where we post many educational endoscopy videos. Basically, I'm presenting them all without editing, so you can watch them all for free if you just register. If you want, please come and browse. Check out, please. Okay, thank you. Thank you for watching my presentations. And how do you think about my procedure? Do you have any question, Professor Dupret?
Well, it was a very nice and straightforward procedure in difficult cases with a recurrent mucosal cancer post-EMR. My first question is about EMR. Do you have some tips to have a successful EMR in these cases? And also your thoughts about cold snare resection of colonic lesions, because there is a recent report from United States showing that there is a high recurrence rate when you remove larger lesions with cold snare without diathermy. What are your thoughts and your ideas about this?
Actually, in this case, the lesion size is not so big, within 2 centimeters in diameters. But actually, when I inject the solutions, non-lifting sign positive. So I think conventional EMR, re-EMR is maybe difficult. The snare may slip.
But I think underwater EMR without the injection solution, I think it's is sufficient procedure for this kind of regions. But I think the rate of R0 resection is higher with ESD than with underwater EMR. And the previous pathological findings shows the high-grade dysplasia. So, and this recurrent region also has some potential of malignancy. So I think other resection is favorable with this case. So I decided to use ESD technique in these cases.
So how can you evaluate the risk of fibrosis and attachment to the muscle in those recurrent cases?
So after ESD, in my experience, after ESD, very severe fibrosis exists. But after EMR, recurrence cases after EMR, in my experience, sometimes the fibrosis is not severe, but actually during the procedure, I can confirm the grade of the fibrosis. Before the procedure, it's difficult to estimate the strength of fibrosis, actually.
So I think in Europe, when there is not so much fibrosis, we would also go for ESD. But in severe fibrosis, for lesions less than 15 millimeter, we would choose FTRD with, for example, the Ovesco system. So
I think this is a good idea.
Is that also practice in Japan and in your center in Tokyo?
Yeah.
To use FTRD?
Actually, the OTSC is released commercially available in Japan, but with OTSC with EMR, the device is not released, not commercially available in Japan. So we cannot use a full thickness resection with Ovesco. Yes, but I think a good idea for the small recurrent cases.
Yes, because there have been series from Europe and from United States about that. Yes.
Yeah.
You discussed a lot in the beginning about the position of the lesion to facilitate ESD, and you changed the position of your patient.
Yes.
Are there other traction devices that you are using in colonic ESD?
In this case, in the colonic cases, we always use ring thread method. Small 1 centimeter small rings and with a clip. I prefer to use in the colonic cases. In the upper GI, I often use a clip with line method, but in the colon, I always use a ring thread method. That's cost effective and easy to use.
That's in the colon and in the rectum also. Or in the rectum, do you prefer pocket methods or tunnel methods?
I don't use a pocket creation, but for the big region, I often use a tunnel. That's similar to the pocket creation, but often I use some tunnel and dissect the remaining palisade submucosal layer.
And in very large ESD cases in the rectum, what is your preferred technique?
My preferred technique is I already published, but multiple tunnel and separated with a palisade submucosal layer technique. So make a multiple tunnel, not use a pocket creation, but use a tunnel. So because tunnel can fasten the endoscope itself and the operation view is stabilized, but pocket creation, the hole became bigger, the endoscope often moves loose and redundant. So I think multiple tunnel is better to remove the huge rectal region.
And then I have a last question about your experience. If you encounter very severe fibrosis, do you pursue the ESD, and do you pursue even at the risk of perforation? And in case you perforate, what is your management then of these problems, complications?
Yeah. In case of severe fibrosis, if the region is located in the rectum, I continue the dissection, and if occur the perforation, after remove the region and then close with the end grip or end loops with the clips. But if the region located in the cecum or deeper side of the colon, I withdraw the procedure. I have some possibility to withdraw. But if I can close the wound completely with the end clip, I think no need to withdraw the procedure. So can close the wound completely or not is very important. Just finish the procedure. So if the lesion is located in worse position and it's impossible to close the wound, stop the procedure. That's important to avoid the emergent surgery.
In a case where you have such fibrosis with a risk of invasive cancer, what is your threshold to go for ESD or to send a patient for surgery? How do you decide how far you can go with these ESDs in these recurrent cases with cancer?
Actually, in colon, I only determine by endoscopic findings or magnifying endoscopic findings. I don't use the ultrasound in the colon. Yeah, only endoscopic findings with NBI or magnifying endoscope. That's only.
And for the fibrosis, you explained that you can use underwater to see, I think, the softness and the softness of the scar or the area to resect, or you can use the lifting to check for adherence and fibrosis. Are there other tricks to evaluate fibrosis before starting ESD?
I inject the saline before procedure. I always perform the pre-operative endoscopy for all the cases before performing ESD. So, and I sometimes use injection with saline before the procedure. But if sometimes the fibrosis was severe and it's impossible to inject the solution, I suppose that severe fibrosis may exist or the lesion may infiltrate to the deeper layer, and I stop to perform and go to surgery.
Right. And I have a question about the knife. You use the dual knife here, but in case of severe fibrosis, do you use other tools or other knives or other devices to have a more precise incision and dissection plane?
I think dual knife is one of the most thin endo knives now released in the world. So, and dual knife is brings a precise dissection plane selection. So I think dual knife is best to dissect the fibrotic cases. Hybrid knife or some kinds of knife is a little bit thicker to dissect the severe fibrosis. So I think thin type needle is better.
And you use the J function to irrigate and to lift. Do you sometimes need a needle when it's very fibrotic and you have a lot of adherence?
Yeah, in the fibrosis, I always use the injection needle because it's difficult to inject with the endo knife to the severe fibrosis. Injection needle is much sharper. So I think in the fibrosis, an injection needle is better. But soft submucosal tissue, jet needle is jet knife is enough.
And this is for sure my last question. When you see fibrosis like this, how can you differentiate benign fibrosis from malignant invasion layers? Are there features to differentiate the two?
I think some doctors say may be different, but in my experience, I think it's impossible to differentiate the benign or malignant fibrosis. I think.
I fully agree. I had a case yesterday also with a yellow adherence to the muscle. It was very difficult to know if it's malignant.
Some doctors say the yellow, but I think I cannot differentiate. I'm sorry.
So I hope I didn't disturb you too much with my questions. I think this was a very interesting discussion, and I learned a lot of things by looking to your video and discussing with you. I really thank you for your great expertise, Dr. Ohata. Thank you.
Thank you, Professor Duprey.